The adductor first described saphenous nerve block ultrasound guided by Kirkpatrick in 2010 but as a letter to the editor in regional anesthesia and pain. He was using ultrasound and color Doppler they referred to as superficial femoral artery saphenous technique, and according to them it seems that it's not necessary to visualize saphenous nerve in order to do the block successfully. And up till 2011, Long and colleagues first applied the concept of performing adductor canal block for the purpose of analgesia after major knee surgeries. They were introduced the first perineural catheter and established that 30 ml of anesthetic could effectively fill the adductor canal. And Henningsen tested the saphenous nerve injury in 2013 to describe the safety of the technique. They demonstrated that no patients suffered saphenous nerve injury and over 80% of the patients have successful block. This study highlighted two important aspects of the technique. Established the technique safety, which I query describe it is not safe as long as you are describing the whole structures in the adductor canal, not only the nerve. And demonstrated that even under controlled conditions, it is not 100% effective. Most of your colleagues will notice this, that it is not 100% block in all cases, I mean. The adductor canal aponeurotic sheath that is extending from the apex of the triangle here to the adductor hiatus in the popliteal fossa and is bound medially by the sartorius, laterally by the vastus medialis, and posteriorly by the adductor canal. Within the aponeurotic sheath, which is triangular shape here, there is consistently saphenous nerve and nerve to the vastus medialis, in addition to the artery and the vein. And outside the aponeurotic sheath, we have the subarterial plexus, which is a group of nerves, branches of the obturator nerve, medial retinacular nerve, the medial femoral cutaneous. The radiologists describing that visualization of the nerve can be done, the saphenous nerve can be easily obtained in the proximal part of the adductor canal using high. Classical teaching for adductor canal block is injecting in the midpoint of the thigh medially, ultrasound guided of course, but midpoint of the thigh, which is between the anterior superior iliac spine and the medial epicondyle, is the red arrow in this diagram. Is it the beginning of the adductor canal? Here is the study 2017 published in Anesthesia and Pain, defining the location of the adductor canal using ultrasound. 22 volunteers with asaphysical status are recruited. It is a prospective randomized controlled trial RCT, and in all volunteers the midpoint of the thigh in red arrow here was proximal to the beginning of the adductor canal in the blue arrow here, suggesting that injection performed at this level is in fact femoral triangle block. This is hence the second name of the adductor canal block is called femoral triangle block, is the second name for adductor canal block. Comparing proximal to the distal in the adductor canal. This is the subject of the study published in regional anesthesia, published in regional anesthesia and acute pain. And by proximal, we describe the left picture, the left photo of this diagram, where there is a sartorius muscle, and beneath is a superficial femoral artery, lying in a more medial location to the muscle. While we are going with the probe more distally, the same superficial femoral artery will move from the medial location to more lateral position. And the block, proximal and distal, the study demonstrated that continuous proximal adductor canal block offers non-inferior analgesia compared to the distal continuous adductor canal block after TKA, which I object for this terminology in English, because as a general rule, while you are going more proximal, you have get a better analgesia. So if he is describing his terminology, it should be like this, that continuous distal adductor canal block offers non-inferior compared with the proximal one.
Now this is the superficial femoral artery.
The adductor canal block
on the medial side
since
of the sartorius muscle under the sartorius cover. This is proximal in the adductor canal block and baby in the femoral triangle. We are going more laterally. The artery is going more laterally, and here is this is lateral, and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the sartorius muscle under the sartorius cover. This is proximal in the adductor canal block and baby in the femoral triangle. We are going more laterally. The artery is going more laterally. And here is
probe more going
lateral,
distal,
and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the first one, but less motor paralysis. Now,
and here is the color in all cases to show the artery. The adductor canal is the color aponeurotic cheese to know your anatomy, extending from the apex of the triangle here to the adductor hiatus. Here is the artery location. And this is bound medially by the artery and vein, laterally by the vastus medialis, and posteriorly by the adductor canal. Within the aponeurotic sheath, which is triangular shape here, there is consistently saphenous nerve and nerve to the vastus medialis, in addition to the artery and the vein. And outside the aponeurotic sheath, we have the subarterial plexus, which is a group of nerves, branches of the obturator nerve. The radiologists describing that visualization of nerve
now the needle is coming from lateral to medial, approaching, penetrating the muscle, and now I feel a resistance. This is the fibrous sheath that covers the adductor canal. Now few cc's. This will block the subarterial plexus of nerves, including the branches of the obturator nerve. Yeah. Now I'm penetrating the resistance. Now penetrated. And the hyperechoic mass, this is the saphenous nerve, inject after withdrawal. Withdraw first, inject, no blood?
No blood.
Yeah, inject. Inject. Yes. Inject. Withdraw.
Withdrawn, doctor. Can I inject?
Inject. Yeah. Now the saphenous nerve is floating now.
Can I inject full?
Yeah, inject. 20 ml total.
Yes, sir.
Give me 5 ml more because you give extra adductor canal. 5 ml. So we need a 20 ml within the adductor canal because the capacity of the adductor canal give 5 ml is around 20 to 30 ml.
Okay, doctor.
Thank you. This is finished.
So, femoral nerve block versus adductor canal block. In which surgery in anterior cruciate ligament reconstruction. Two studies came from Arabic researchers. The first one is assistant professor in Ain Shams University, very good researcher, Muhammad Said Al-Ahl, and he's working in Emirates. And the second one is Faraj Abdullah, he's working in Toronto General Hospital, and he's from Lebanon. And the first one published in Saudi Journal of Anesthesia 2015, and the second one published in Anesthesiology 2016. Both are studying. They have a randomized controlled trial comparing the adductor canal block with the femoral nerve block for ACL reconstruction. Both are randomized controlled trial. Both groups superior quadriceps strength in the adductor canal group, and pain control differed in the two groups. Abdullah found that both groups are equal. I mean, it's effective as the femoral nerve block. While Muhammad Said Al-Ahl reported lower pain intensity around 18 to 24 hours in the group with having femoral nerve block. So discrepancy could be attributed to the nature of the graft in the two groups are different, and the volume of local anesthetic 20 ml in Abdullah group, 15 ml in Muhammad Said Al-Ahl group. So we need additional trials to confirm. And in 2017 I have met this is Faraj Abdullah. I met him in Abu Dhabi while I'm giving a lecture about the knee pain, and he was giving another lecture about the same subject. And he told me that the difference between his study and Muhammad Said Al-Ahl, he confessed that he was injecting more proximal, actually in the femoral triangle block, midpoint of the thigh. So this can also explain the better results for the adductor canal block in Faraj Abdullah. So also in the total knee, the adductor canal versus the femoral nerve block, meta-analysis published 2017 by Duan in Scientific Reports, and it included 12 randomized controlled trials. Adductor canal block provide pain relief and opioid consumption comparable to the femoral nerve block and is associated with decreased. Another study 2018 having another aspect of in the total knee block, that early rehabilitation and lateral knee pain relief. It is a randomized controlled trial, similar analgesia for both groups, adductor canal and femoral nerve block. Opioid consumption, complications, occurrence, sleep interruption caused by pain, all are the same. In addition, adductor canal block having better rehabilitation, I mean better movement, but early rehabilitation is associated with lateral knee pain. So adductor canal block could not relieve lateral pain on early rehabilitation. If we are adding to the abductor canal block obturator nerve block, this is study 78 patients, 3 groups, femoral nerve block in addition to the adductor canal block, 1 group. Adductor canal block is the second group, and the third group, local infiltration analgesia. So obturator nerve block, if added, addition of obturator to femoral nerve block, femoral triangle block, I mean adductor canal block, reduced opioid consumption, and pain after TKA compared with the femoral triangle block, which is adductor canal block, or local infiltration analgesia alone without impaired. The adductor canal block in comparison with the local infiltration analgesia systematic review, 6 randomized control trial, periarticular injection significantly improved post-operative pain relief and opioid consumption when compared with the adductor canal block. Additional high-quality studies. To have more bad news for the adductor canal alone is a case report by Faraj Abdullah from Toronto General Hospital and Lyon. Femoral artery dissection after adductor canal block, uneventful ultrasound-guided adductor canal block, post-operative absent distal pulsation and arterial duplex scan demonstrated femoral artery dissection flap. Color Doppler demonstrated absent arterial flow to the distal to the dissection, and at surgery a puncture site with perivascular hematoma and intravascular thrombus emergent thrombectomy and arterial repair. The patient subsequently regained. The last is the IBAC block. The first introduced by Sanjay Sinha from New York. And the IBAC block stands for infiltration between the popliteal artery here and the capsule of the posterior knee here, blocking the articular branches of the tibial common peroneal obturator nerve in the popliteal. The injection is done while the patient lying supine, flexed knee, the needle passing from medial to lateral between the artery and the capsule away from another study 2018 confirmed what Sanjay Sinha presumed. The frequency map of articular branches, where the posterior branches of the common tibial fibular nerve, sciatic nerve are in red, the posterior division of the obturator nerve in blue, the superior branch of the tibial is in green, and the inferior branch of the tibial in violet. This is published in 2018 by a group of investigators from Toronto, mainly Philippine, the head of the department. And according to the study, the frequency map of articular branches provide anatomical basis for the development of new clinical protocols for knee radiofrequency denervation and perioperative pain management. And his technique, newly developed technique, it was described in the ASRA meeting, the 14th ASRA meeting, the 41st ASRA meeting, and he is describing the safety of anesthesiologists administered ultrasound-guided periarticular injection, liposomal bupivacaine femoral artery. And what he described, two groups. The first group, continuous femoral nerve, this is a control group, continuous femoral nerve block with single shot tibial nerve block, while the study group, single injection femoral nerve block and IBAC block, single injection. In the study group, he was recruiting 1189. It's a retrospective study. He was doing short-acting femoral nerve block with mepivacaine 1%, followed by 60 ml injection of local infiltration analgesia, a mixture of liposomal bupivacaine, and saline. The control group, as we described, received continuous femoral catheter with ropivacaine, total 25 ml, followed by infusion of ropivacaine 0.2% for 48 hours and single injection of the tibial nerve block. In the first 24 hours, the study group, which is the red in color, having more pain intensity than the control group, which is having the continuous femoral catheter injection. However, after what is astonishing that after the first 24 hours up to 72 hours, we have extended analgesia from the single injection of the IPAC block combined with the single injection of femoral artery block, short acting. So this is
artery against the lower end of the femur, and this is the posterior capsule, the white line. I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block.
Still we do not have any.
I am infiltrating between the posterior artery and the posterior capsule of the knee, and you see to the left of the artery the two branches of the sciatic nerve we are injecting away, so no motor block.
The injection
from
is done
medial
by the patient by spine,
lateral.
the needle passing from medial to lateral in the artery,
And we are
away from
deeper
the branches.
to the artery. Now in the against the posterior capsule, now inject. Yeah, injection now between the capsule. Any resistance?
No.
Okay. Give 5 ml.
Yeah, I will give one.
Stop. Now I am redirecting the needle to go more laterally. Now, yeah. Now inject. 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 Yeah, this is the lateral injection between the capsule and the
Can I give
popliteal
full
artery.
dose?
Give full dose. Thank you. Done.
So I realized that I should compare what is the effectiveness of this IPAC block, and to compare this, what I did, I added the adductor canal block to the IPAC block. I am doing it pre-operatively before the surgery is starting, and the control group is I'm doing it pre-operatively the adductor canal block and letting the surgeon doing local infiltration analgesia at the end of surgery. And cohort study I published in the Journal of Anesthesia and Critical Care. A combination of adductor canal block, IPAC block is better than the combined adductor canal block and periarticular injection done by the surgeon for painless ACL reconstruction. And validation of these results is essentially requires further RCT with a sample size. However, I didn't find this comparison in RCT except in another type of surgery, which is TKA. The first one is published in 2017 by Salman from New Orleans. He was studying 3 groups. The first group, femoral nerve block. The second group is femoral plus IPAC block. And the third group, adductor canal block plus IPAC block. And what we got, IPAC block reduced opioid consumption if added, whether to the femoral nerve block to adductor canal block. Adductor canal block with IPAC block provide equivalent analgesia to the femoral nerve block and the IPAC block. Physical therapy is easier, no motor block, and allowing earlier hospital. The second group is published. The second study that RCT that described this triple block in comparison with the periarticular injection. He introduced it in the World Congress in 2018 in New York, and I was submitting another paper about quadris lumborum in the same Congress, and he described a triple technique. He was giving adductor canal block, IPAC block, in addition letting the surgeon doing local infiltration analgesia at the end of surgery. So he is doing double block before surgery and letting the surgeon doing the third block at the end of surgery. This is Kim. And the control group is local infiltration analgesia. By adding the IPAC block and the adductor canal block to the periarticular injection, the patient received significantly better pain control in postoperative days 0, 1, and 2. This study strongly supported the addition of IPAC and adductor canal block to multimodal analgesic pathway. And the strongest message from this study is that with such triple combination block, pain scores on ambulation was reduced to an average of 1. The same combination, which is adductor canal block and IPAC block, was used in pain relief. This study published in Anesthesia Essays Egyptian Journal by Said Imam and Ines from Mansoura University. They were injecting this combination and comparing with the adductor canal block. The technique combined adductor canal block IPAC block provides more effective analgesia and better functional outcome compared to the adductor canal alone in patients suffering from arthritis. Just to hint that there is more promising techniques, which is quadratus lumborum and which is the article of another two lectures that I'm intending to publish also to put it on the group, which is thoracolumbar fascia, understanding thoracolumbar fascia and quadratus. And this gentleman, Rafael Blanco, he's working with me in the previous duration in Abu Dhabi, in nearby hospital. He was the one who introduced quadratus lumborum. And the other lecture, which is erectospinal blame block versus paravertebral block. This erectospinal blame block introduced also by Mauricio Forero from Canada. I met him 2015. He was the instructor for one of the instructors of the training group in Toronto. And the take-home message of this lecture is pain management for the knee should be thought of as multimodal rather than monotherapy. Combination of paracetamol and NSAID is safe and highly effective, particularly if started pre-operatively. Opioids cannot remove pain or movement, therefore not the ideal single therapy for rehabilitation. And the motor sparing peripheral nerve blocks result in faster return in normal life activity. Extended analgesia with single injection of combined block is becoming a reality with introduction of ultrasound-guided regional block and added adjuvants. The synergistic effect of combined blocks probably prolong the duration of sensory block. The most effective practice for pain control is by incorporating preemptive analgesia, multimodal analgesic regimen with paracetamol, NSAID, and gabapentin, and a combination of motor sparing regional techniques that target the terminal sensory endings of the femoral obturator and sciatic nerve are the best. If anyone interested to join me in WhatsApp, here is the WhatsApp numbers. I'm welcoming any question or any illustration or clarification. Thank you very much.